Thank you. And again, since this is the last big group thing, I'd really like to thank you guys again for having me here. It's really been really fun. I've really had fun talking to the guys. I now have a new favorite tree that's tempting me to want to move here, at least for the 2 weeks it's in bloom during the year.
Do you remember what it's called?
Jackberry. But I will. Yeah, I was chasing an ibis, which I then hear like the scavengers or like the pigeons or whatever. It's okay. It's still cool. No, I will report back if I can find a way to get seeds for this tree and bonsai it in Boston. Anyway, what I was asked to talk about now are less common signs and symptoms of TSC and less well-known signs. And I think that, again, the reason for this is, and again, I think the reason for trying to look at a group of people with TSC, a large group, is I do think it helps us understand TSC better. And so the purpose of this is not for everyone here to say, oh my God, there's even more with regard to TS, because most of the things we're going to talk about are things that I don't think are clinically significant, but they're things that we have seen in a couple cases. I think it's important to know about them. There are a couple of things which may be clinically significant, and I think it's just we don't really understand a lot about it yet. And again, since our mission is to keep people with TSC healthy as possible and also to understand TSC as much as possible, I think anything more we can learn about this disorder can only be helpful. So first of all, what we'll start with is the brain and the skin. And as you guys know, we've talked about, the brain and the skin are both affected in 95% of individuals with TSC. And we know the common signs, but we're going to talk really briefly about what else is there. And then kind of aside from the brain and the skin, what are the other signs and symptoms, mainly signs in TSC, that are less understood or haven't really been, until recently, thought to be part of TSC. So this just, again, we looked at this yesterday, but this basically shows you the major criteria for diagnosis and kind of lists all of the things we typically look for in the skin and all of the things we typically look for in the brain. So those are the things we know happen in TS, but what are some things happen that aren't necessarily as well understood? So what I'm going to talk about first are two things in the skin, and the reason I mention these again are not, they don't complicate health, but I've had many people with TS told by dermatologists that these aren't part of TS. So I think people with TS need to know that these things are part of TS. And that's skin tags and erythematous cholangioma. And I'll just take you back to my picture of my friend Michael from yesterday. And I don't know if many people noticed this. So here are the angiofibroma, there is the forehead plaque. That is an erythematous cholangioma. So those are not uncommon in people with TS. And what it is, and Tom Darling, who's the big dermatologist in the US, and I we talk about this a lot, but it's an erythematous region, sometimes a little bit raised, and it's on one side of the face, rather often along the jawline. Again, not part of criteria, not minor criteria, but we definitely see it. And I've had too many people said, oh no, that's not TS. So that is TS. And if those are bothersome to people, a couple of our kids really don't like them. Laser therapy can help take out the redness. We're actually trying topical rapamycin on a couple now to see if that helps. One of my African-American patients, she is the coolest. She has a large one of those. So she just tears her hair short on that side and hair coming over here. To hide it. But those can be very difficult for some people. And then the skin tags, I don't think he really has them, but skin tags any of us can get. But people with TS can get literally hundreds of them on their neck. And those can also be really bothersome to people. That is also part of TS. And the dermatologist can very easily remove those. So those are the things that we see in the brain that many people don't get, or the skin. And then turning to the brain, and kind of, again, what we talked about already were the things we know. And then just very briefly, these are things that we have seen by looking at lots of brains and trying to figure it out. Again, nothing to be alarmed, oh my gosh, what else does this mean? But something that just to think about. So first is cyst-like tubers. And kind of, if you look at an MRI, and we looked at these earlier on the scan, what you can see are these areas here that look darker. And that's under the cortex, that's white matter. And if a radiologist looks like that, it looks like a cyst. We don't think they're cysts. And these basically, when I first started seeing these, it was one of my more impaired kids, and I thought, oh my gosh, this is like malignant TSC. Then the next time I saw a scan like this, it was in a 3-year-old who's precocious, has never had a seizure, but has TSC. So we've looked at this a lot. Some people have just a single cyst-like tuber. If so, that's the seizure focus. Other people have all of these, and we're trying to understand what these mean, because this is something in childhood, and then they appear to go away. So these are not destructive lesions. I think it's telling us something that's going on in the white matter, some process that's causing this signal change, and we're trying to figure it out. So if anyone ever looks at a scan of anyone in your family that has, in one of the ones shown earlier that actually you showed, had some cyst-like tubers in it. And so it's nothing to be alarmed at. We don't think they're bad. We just don't understand them. Then also, so this goes through them, they're very common, so 46% of individuals, and we do send them related to epilepsy, but we don't really know what the significance of that is. So then the other thing that's seen is calcified tubers. And it's not unusual for people to have calcified tubers. Oftentimes a person with TS will only have a single calcified tuber, and if there's a single calcified tuber, I'm often willing to bet that that's a seizure focus. Because we think the seizure activity causes an inflammatory response, disrupts the blood-brain barrier, and then lays down calcium. Sometimes people do have more than one calcified tuber, and I don't really understand that, and we're trying to figure that out. But again, in the old textbooks, tubers can undergo cyst-like degeneration and calcify with time. They can, but typically it's only one or a few. So then the other things that we started noticing, and this was someone who was working with me who liked to look at MRIs a lot, and kind of if you do an MRI on anyone in this room that does not have TS, it's very likely you would find something called an arachnoid cyst. On MRIs done for migraines and MRIs done for lots of things, there will be the incidental finding of an arachnoid cyst. And these are arachnoid cysts. That's a kind of a larger one. This is a smaller one, and there's a smaller one. But we noticed that people with TS have arachnoid cysts. So Susanna looked at this, and we kind of saw that they were 5%, almost 6% of people with TS in our population have them. That compares to the 0.5% in the general population. So they do appear to be more common. There were 2 previous case reports of arachnoid cysts in TS. And what we saw is that about a fourth of the folks had more than one. The majority of people that had these were male. Interestingly, a third of the people who had arachnoid cysts had a contiguous gene deletion with PKD1, and only in 1 of the 12 did they grow. And in the general population, that incidental finding, we usually do not think that they're clinically significant. So I really don't think they're likely clinically significant in TS. But then we also saw some where you see the cyst, and you see that there's kind of deformation of the bone over it. And so we don't know what that means. But what kind of overall, we think that they are more common in TS. They're often multiple. As we said, more common in males than those with TSC2, PKD1. They're usually asymptomatic, although this signs of long-standing mass effect with that remodeling of the adjacent bone, frequently present. 0 symptoms, but if you look at the scans, you can see that. And then also we do see these in some of our folks that meet clinical criteria. We know they're mutation who do not have tubers and subependymal nodules. So we're trying to think of what's the pathogenesis, how do they come about. And then interestingly, sometimes you'll see TS folks that maybe might have angiofibroma on one side of their face but not the other. And if there is unilateral, clearly asymmetric facial skin lesions, the side of the arachnoid cyst is the same side as the more significant skin lesions. So again, we're trying to figure that out. Then this is another thing that we have seen that had been in the medical literature in many case reports but never pulled together. And this is the thing I think we need to watch in the future to see, is there a clinical significance to this? And that's intracranial aneurysms. We looked at our population, saw 3 of 404 patients that we had very fancy MRIs on had these. So that was twice the general population, twice the percentage. And then we also found one in a person that has possible TSC that I think does have TSC, just doesn't meet criteria yet. 2 had a TSC1 mutation, 1 had a TSC2, so concur with either gene. 2 folks also had a duplication of the superior cerebellar artery, which is just one of the blood vessels in the brain. And as I said, in the medical literature, there were 31 prior case reports, including 4 folks with TSC PKD. These can appear early. The youngest kid we had seen one of these in is less than a year of age. They typically affect the internal carotid artery, although we also have a kid now with one in the vertebral artery. Prior to puberty, if we see this, they're more common in males, and also in the case reports. After puberty, it appears to be equal, male and female. And this just shows one of these. So this here, what the arrow's pointing to is this little aneurysm, and then this is that child a couple years later, completely stable. So what we think here is that in tuberous sclerosis, they appear to be more fusiform, which is just the type of aneurysm, giant and occasionally multiple. We also see normal anatomic variants, such as those superior cerebellar arteries. That may be more common in TSC. May be seen in TSC similar to the arachnoid cysts. We sometimes see this vasculopathy, as we call it, in folks that don't have tuberous and subependymal nodules, but there's really, really limited data on the clinical significance. 10 of the 34 in the literature had symptoms, so about a third. None of our folks have. 2 had an intracranial hemorrhage, and 6 had compressive symptoms, from the aneurysm getting large and putting pressure on the brain around it versus the hemorrhage from the aneurysm rupturing. So what we are trying to do, and we spend a lot of time, the MGH has a very intense interventional radiology group who think a lot about how do you deal with aneurysms in the general population. And if you look in the general population, a lot's been done at natural history of intracranial aneurysms. Depending on the anterior circulation here, where we see them usually with TS, those are less likely to bleed with time than those here, but they do it by size of the aneurysm, et cetera. And what we were talking about is that's in the general population with aneurysms. We don't know anything about that. So pretty rare in TS, right? 34 total cases, but I think it's something that kind of as a medical community, you guys shouldn't worry about, but we need to think about. So now when we do our brain MRIs, our radiologists look very closely at the vessels to see is there any evidence of an aneurysm. Okay, and so then what else is there? And we're just going to run through some of these. Growth and size. Interesting, I met a new baby for the first time last week, and the grandfather asked me a question he thought I was going to be very annoyed by. The kid is 9 months old and is 95th percentile for every growth parameter. And his family are not very large people. So the grandfather said, I've annoyed people for asking this question, but is it possible he's just bigger because he has TS? And I actually thought it was a brilliant question, because we're talking about a dysregulation of the mTOR pathway, so why couldn't dysregulation, just like it makes the fly's eyes bigger, why can't it make the whole person bigger? That's, I don't think, ever really been looked at. And I think most people I take care of with TS are not so different in size from their families. But we also do know that some folks will have hemihypertrophy. I have a couple kids where one leg is larger and longer than the other. And also, we were talking last night, there are also people who have isolated hypertrophy of certain parts of their body is just bigger than the other side, and then this gigantism, like this kid who's just much bigger than everybody else. What we are going to talk about, because it matters clinically, or it could matter clinically, is in the lung. Lisa talked a lot about LAM. But the other thing that happens very frequently in the lung is called microfocal micronodular pneumocyte hyperplasia, and we're going to talk about that. I am in pH. Look, how long does it take you to say lymphangiectasia, right? Or so you can just call it MMPH. But we're going to talk about that. The reason we're going to talk about that is because I take care of a person who is misdiagnosed as having metastatic melanoma and treated as such. When what she really had was MMPH. And so MMPH is something everyone with TS and people taking care of people with TS need to know about, but it is not clinically significant. It's mainly to know it's there so it's not confused for something else. Then we're going to talk briefly about lymph system involvement, and then really quickly run through liver AMLs, colon, rectal polyps, cardiac lesions in adults, thyroid nodules, bone lesions, and then at the end come to something we're really spending a lot of time on now, and that's really looking at malignancy and TSC. So first, this MMPH, it's kind of in the name. Multifocal means many places. Micronodular means little nodules. Pneumocyte is one of the cells in the lung. Hyperplasia, overgrowth. Affects men and women with TSC, so not just women. It is not clinically significant. At least we've looked at this now for over 10 years, and we have had no cases where it's had any clinical significance. Very common, and again, it's really important. Being treated for metastatic melanoma pretty much ruined this woman's life, and I still can't believe it happened. Anyway, as we said, it's a proliferation of these type 2 pneumocytes in the lung. It's often accompanied by septal alveolar macrophages and interstitial reticulum, and on the CT scan, solid or ground glass nodules. So when we first started thinking about this, we get the high-resolution chest CT looking for LAM. No LAM, but gee, there's this nodular disease. Follow-up's recommended in 6 months to rule out metastasis. But now we see this, and kind of we looked at this, and when we looked at it, we saw that 58% of people with TS have this. And as I said, it's as common in men as in women. And then the nodules, you can see solid, ground glass, and both solid and ground glass. And because we weren't sure, I think the thing that I've learned with time is you never say never with TS. And so we just started seeing this, and I didn't want to say, this is nothing. So we did follow these up initially with chest CTs, and we basically almost without exception, the nodules stay the same size and stay the same size and number. We've had a couple of the nodules that have grown a little bit, but still no symptoms at all. So again, just important to know that it's there. Then the lymph system, and this kind of again come up. We were seeing a lot of all these kids, and we have a extremely wicked detailed database on our TS folks trying to understand this better. And the person entering in the data came and said, you know, Elizabeth, it seems like people with TSC have lymphedema a lot. And so we decided to look at that as interested because lymphangiectasia, lymph, suggests involvement of the lymph system. And so now we're thinking lymphedema. And kind of since the lymphatic system is thought to be involved, and it's actually been hypothesized as one of the sites of origin for the Lamb cells. And so we looked at this. And what we saw that it's about 7% of people with TS patients that we've seen have lymphedema, 5 with congenital lymphedema, meaning they're born with it, and I'll show you a picture of a little girl we follow with that. 9 with acquired lymphedema of upper lower extremities, just swollen ankles over time without any other cause. 6 men with scrotal edema, which is on the lymphedema spectrum. And if you look at this, this is much more common with the TSC2 mutation that occurs in others. And this is this little girl. So this little girl was born, and this was noted at birth. She was later diagnosed with TS after developing infantile spasms. But you can see this marked enlargement. It's also a little bit hemihypertrophy, so the leg's a little bit bigger, but if you see this and then this area here, and if her foot was so disfigured by this lymphedema, her grandmother, who's her legal guardian, couldn't even think about painting her toenails because you couldn't see her toenails. Then this is the MRI, and this is what's really striking. So here she is standing up. This is her right leg, and here's the left leg. There you can see the muscles, and here you can see the muscles in the bone here. That was unfortunately not there, so it's pretty normal. But what is not normal is this massive amount of lymph tissue. Now, when we saw this, and this is very disfiguring for this kid, there's no treatment for lymphedema other than compressive stockings and water, swimming. Thought, well, gee, this is probably something related to TS. So we put her on rapamycin, and this got significantly better. In fact, she started getting her toenails painted, and it was a huge deal for this kid. So again, thinking that if you see something unusual and yet maybe it's related to TS, could it somehow be related? And therefore, could we think of how could we treat it in other situations? Then this is a rare thing, and this I've only seen once, but again, tells you something about TS. And this is a little 2-year-old girl we saw who TS was raised prenatally, multiple cardiac rhabdomyomas. She had cord blood analysis, and her mutation was found. So she had a genetic diagnosis prior to birth. Seizure onset, or I guess it was after birth, but from cord blood. Seizure onset at spasms at 3 months of age. And when we saw her, we kept being impressed that she really looked like a Buddha belly. So initially I was a little worried she had polycystic kidney disease, and this abdomen was gigantic kidneys. But what it was is just a large belly, and then our mom told us that she had had chronic diarrhea. And the mom had discussed this with the pediatrician, who wasn't too alarmed. We were kind of alarmed with this and that. So we sent her to our GI folks, and they diagnosed her with a protein-losing enteropathy. And then basically abdominal imaging showed multiple dilated bowel loops, normal kidney, liver, and pancreas. And she had a biopsy that showed dilacted lacteals, which led to the diagnosis of this other fancy word, lymphangiectasia. So that's a rare thing, cause unknown. It results in a protein-losing enteropathy. So again, here's this kid. She needed to have albumin infusions twice a week. She also was low immunoglobulins because she was pouring them all into her gut. So we thought, again, initially tried altering her diet, albumin infusions. Her VEGF, which remember can be elevated in women with the Lamb, but this is VEGF-C, which is a different one, was high. And we started her on rapamycin. Again, thinking this has got to be somehow a rare possible manifestation of TS. She's almost completely recovered from this, which is great because if she hadn't, the only other treatment option would have been either TPN for life or a bowel transplant. So again, rare, but I think telling us more about the spectrum of TS. So then just really quickly, run through these other things. I think everyone here hopefully knows it's one of the minor criteria, but liver's involved a lot in TS. And people get very anxious about this if they see things in their liver. So about 30%, we've looked at this. And what I think what it is, it's AMLs and cysts are seen, and the AMLs in the liver are more vascular. So sometimes they're actually called hemangiomas, but I think they all come from them same cells that just kind of turn into different things in different places. They can grow over time a little bit, but in my experience and in the literature, these have not been clinically significant. So whereas we watch the liver ones, the kidney ones for fear of bleeding, the ones in the liver are there. They do not affect liver function, and we have not seen them be clinically significant, but we follow these, again, because you never want to say never. Colonic rectal polyps, they're also minor criteria. These can be significant. And again, a lot of the GI doctors don't really understand that this is a possible manifestation of TS. And I have a couple of folks that on colonoscopy, they just don't have 1 or 2 rectal polyps. They have thousands. And then the concern is, gee, because we know it's rectal polyps that increase the risk of colon cancer. So far, we don't think that there's an increased risk, but that's one of the things we're looking about when we come back to malignancy. But important to know, because I've had a couple of GI people just completely freak out. One parent that came to see me, a young adult, told me that her daughter's colonoscopy showed her colon looked like shag rug. And literally, she has thousands of polyps. So far, they are not bothering her, except every once in a while she has rectal bleeding from them. But again, a TS thing. And I think we need to spend more time really trying to look at that and the significance. Uterine fibroids, I think a lot of people here know that they're common in TS, but they're also common in the general population. So it's never been possible to say, are they more frequent in TS than in the general population? And then the other thing we see a lot in TS that I do think is related are lipomas, which are just fatty tumors. Those are also common in the general population, but people with TS can get them. And I think it's if the little cells migrate to subcutaneous tissue or some way, then the fat component of them predominates. So we've had people with pretty significant, one young woman needed to have surgery for a lipoma that was putting, an extracardiac lipoma that was putting pressure on her heart. Another little girl had one that was really significant behind her knee that needed to be removed. And then this 70-year-old I diagnosed last week pulls up her sleeves and says, I don't know, could all these bumps be related? And she has probably about 10 lipomas, subcutaneous lipomas on both of her arms. So again, something I think is related to TS, does not cause, with those rare few exceptions, that extracardiac lipoma, does not cause medical complications, but it's trying to tell us something about TS. Then cardiac. You guys know cardiac AML, the cardiac rhabdos, or the cardiac manifestation. Several years ago, we started seeing, and also a group in Germany started seeing on these chest CTs, we're doing masses in the heart muscle, not in the ventricle, but in the heart muscle of adults with TS. So we looked at that, and we see them in 1/3 of adults with TS. And at first, they mainly look fatty, so what are they? And then we had the opportunity to get a tissue diagnosis from one that had muscle fibers in it. So again, they're angiomyolipoma, where the fat cells are predominating. Those also, to date, do not appear to be clinically significant. But it's another one of those things, I'm not saying we know everything we need to know about TS. So we actually have, if they're significant, we have our cardiologists follow these people just to make sure they don't have any impact on heart function. So far, they have not. The German group that's been looking at this found even higher. I think they found 70% of adults with TS have these. We recently, again on our chest CTs, started having all these reports of thyroid nodules. Thyroid ultrasound, recommended to follow up due to the possibility of thyroid cancer. So what we found that thyroid nodules are also common in TS. 20% of TS, people with TS will have them. Again, important to know, because they're common in TS, thyroid cancer is not common in TS. So, and often, most of the time, more than half the time, these thyroid nodules are multiple. And again, the reason to know all of this is because if any of you or your family member, if they have any of these done and you see all this, then it's good to know about. But I think it's also good to know that these are things that we see in TS and usually are not clinically significant. And then bone. Bone's been interesting for a long time. Bone actually, for years, and if you've ever seen the reports of your CTs or your MRIs or any x-rays, it talks about sclerotic bone lesions. And those are areas on bone, if you look at the x-ray, that look hyperdense. They just look thicker, and we don't know what causes them, but we've spent a lot of time now looking at this and have a paper and press on this, that we see these in kids as young as 2. Again, why that's important and why we tell people about these is because another thing, if you're being worked up for a malignant disease, one of the things they do are bone scans. And if you see any abnormality, you could say, oh my gosh, is this a metastatic disease? But it could also be one of these. So again, important to know. And those are not clinically significant. However, rarely, and this is rarely, people with TS can also get fibrous dysplasia. And that is like a proliferation of bone. Oftentimes it doesn't matter. We've had a couple people now that have had fibrous dysplasia of one of their ribs, including a little boy who it started expanding. We started watching it on scans as well, and the fibrous dysplasia extended back along the rib to his vertebra and kind of began to involve the vertebra and put pressure on his nerves. So again, got to be part of TS. So again, we put him on rapamycin, and that completely abated the process. So kind of, I also like to simplify the universe. So if a person with TS has something else going on, like one of these kind of weird things that no one's ever seen, first thing is how can we relate that to TS? Because lightning usually doesn't strike twice. Sometimes it does. So, and then kind of turning quickly to cancer, because over the past couple of years, this has been a large focus, particularly of a couple people in my group. And you heard last about the renal cell carcinoma. Several years ago, again on our scans, you can get AMLs in the pancreas. And there was actually one of my adults that had a lesion in his pancreas, and I'm like, oh, it's an AML. And then he had to have an emergency appendectomy, which is probably a good thing. And the surgeon didn't like the look of this thing in his pancreas at all. And I'm like, oh, it's probably an AML. But they really thought it should come out, and it ended up being a pancreatic neuroendocrine tumor, which now we've found in about 8 or 9 people with TS, and we've heard of people elsewhere with these. Our pathologists would say pancreatic neuroendocrine tumors are never completely benign, and this is a little debated in the TS community now because do you really need to do anything? Our pathologists believe you do, and I do know of 2 people, one in the UK and one in the west coast of the United States, that have metastatic pancreatic neuroendocrine tumors are not going to make it. So what we do is we do operate on these, and all the operations, some of them have been done laparoscopically. There have been 0 complications of this. No one, you take out part of the pancreas, you're going to have to supply the person with insulin. No one's had difficulty with that. But again, important to know that that is a rare occurrence in TS, but it can happen. The other, and the one that really prompted us on this mission, is chordoma is a wicked, wicked rare tumor. It usually occurs to people in their 60s or 70s. And it occurs either at the top of the spinal cord or the base of the spinal cord. Very rare tumor. And several years ago now, we had a baby born with this at the MGH, and then a kid came from Wisconsin for proton beam therapy for this, because it's a way to treat these clavicchordomas. And he had a seizure, got a scan, and someone questioned TS. So I go in and I talk to the mom, and I said, lightning hardly ever strikes twice, but he definitely has TS, but we don't see chordoma in TS. And that day I went to the meeting and heard about this baby with chordoma in TS. So we now know that this is a rare occurrence. And we had a kid come from Utah with chordoma, again for proton beam, who at the time of his diagnosis of his brain tumor, the incidental, and this is like fingernails on a chalkboard, the incidental finding of TSC had been made from his brain MRI, no symptoms of TS. And that boy spoke to my soul and the soul of one of the people that works with me, who ended up taking a year and a half off of medical school to really try and begin to look at this malignancy. Because all of these tumors, renal cell carcinoma usually affects people in their 50s and 60s. Pancreatic neuroendocrine tumors affect people in their 50s, 60s, 70s. Chordomas, 60s and 70s. And at least these 2 are pretty amazingly rare. So why do we see them? We see them rarely in TSC. So don't worry about having these. Rarely in TSC, but they're occurring in children with TSC. The youngest renal cell carcinoma kid I have is 4. Youngest pancreatic neuroendocrine tumor kid is 6. And the chordomas, a couple babies. So we're trying to figure out what that is. And then the other thing we've been doing is we get this question a lot, especially once the TSC1 and TSC2 proteins were put in that mTOR pathway. Does having the TS increase my risk of other cancers? And that's a question no one's ever been able to answer. So we're trying to look at that, and it's very hard to do because you have to look at incidence of cancers like breast cancer, skin cancer, colon cancer, prostate cancer in our TS population compared to the general population. What I can tell you is I don't think having TS greatly increases your risk of having cancers. It might be at the end of the day, is there a slight increased risk for something, but it doesn't really increase the risk, which I also think is important for people to know. So we spend a lot of time thinking about this, mainly because I'm still trying to figure out TS. And I think how can these less common or less well-known signs in TS help us understand the disorder? Do some result from the circulating LAM cells, and Lisa knows this is my big hypothesis, that those cells in the blood can go anywhere. And depending on where they are in the tissue environment of where they end up is how they proliferate. Is it more muscle? Is it more fat? Or is it more blood vessel? With the cardiac AMLs, which are mainly fat but have some fiber, muscle fibers, the hepatic, which are oftentimes more vascular, and the lipoma, which are almost pure fat. And also, how can identifying these things impact clinical care? So for instance, at the MGH now, we do abdominal imaging, not just renal imaging. And if you read our radiology reports, I have to tell families it can be a little intimidating because our radiologists are so super into this now. You get a 2-page report on the abdominal MRI describing everything. And then also that would extend kind of also, like I said, to our brain imaging, trying to better understand this thing about the aneurysms and how and where and what and when to do about them. And as I said, I think the main thing is the awareness that these are part of TSC. Both the aneurysms, so someone says, oh my gosh, you also have a brain aneurysm, but importantly that MMPH and the bone lesions, because I've seen more than one person get inappropriate medical care for something that is a benign manifestation of TSC. And then again, kind of can understanding all of these help us keep people with TSC healthier? And I think they can. We need to figure out the aneurysm. It's rare, so don't be anxious about it, but they're there, and we need to figure out what is the natural history of those in TS, so our interventional radiologists, who are extremely good at coiling those aneurysms, we know when and where and how to why to do it in TSC. So I do think it's important to kind of further the phenotype or the signs and symptoms of the disorder to better understand it and to keep people healthier. And then I just wanted to say, it's been great fun for me to be here, and I'm very proud of kind of what we have at the MGH, but I have an amazing number of people who work with me. Lots of medical students, lots of people come take time off of their training and extra time, and then also an incredible number of specialists who not only take care of people with TS, but are also really trying to figure it all out to make things even better. So thank you guys very much. I've had a wonderful time being here.